first speaker is Susie Mathis. She's an exercise physiologist. She's also the coordinator of our Cardiac Rehab and Wellness Center, and she's going to be talking to us about the importance of rehab. Susie?
Exercise is very important. The aerobic exercise is important as well, okay? The stronger your heart is, the better able it is to pump blood more efficiently. So exercise is just like putting in premium gas in the tank. Well, there's also the psychological part of cardiac rehab, and that's probably where it is the most important. So let's see, number 2. So we were talking a little bit about the benefits of the physical, thank you, part of cardiac rehab. So as you can see, it can help reduce risk factors that lead to heart disease, okay? Many individuals kind of have heard, I mean, there's better things out in the media now about the risk factors that lead to heart disease, okay? What are some of those? Just offhand, you guys all know these. Overweight, okay? That's a good one because as you lose weight, hopefully that'll impact some of the other risk factors that are associated with being a little bit overweight, okay? Such as what? Overweight can affect what? Blood pressure? Blood pressure? What else? Okay, smoking can too. You know, you wouldn't think about it, but sometimes people have certain tendencies to do things to help cope with stress. Maybe smoking is one of them. Maybe overeating is one of them, okay? Exercise can help alleviate that. Even exercise can help with smoking. You know how? Every time you want a cigarette, go for a walk. The further you are away from them, maybe you won't smoke, right? Okay? What else, though, with being overweight? Okay, and stress. Diabetes. Exercise is wonderful to help improve insulin sensitivity. What else? How about cholesterol? Cholesterol is another risk factor for heart disease. So as you go through cardiac rehabilitation, education on these risk factors to say, what can we do for you to help lower these risk factors? Because you've had an event, perhaps you've had a procedure. Maybe the procedure was to have an angioplasty and a stent. Maybe it was bypass. Maybe it's something to help treat a heart arrhythmia. But the education is very important to help reduce the possibility of having another event happen, okay? What are some of the risk factors we can't control? We can control diabetes, we can control blood pressure. What are some of the other things that we really can't control? What's that? Genetics. If you know what's in your family for heart disease or even some of the risk factors such as high cholesterol, high blood pressure, it's very important to have things checked. Very important to see your physician regularly so that they can check these things before you have an event. So although genetics does impact it, knowledge is good. Knowledge is good. Okay, what's something else you can't change? Age. Nah, yeah. Okay? Sometimes too, males are a little bit more at risk. And can you, if I go like this, can you pretty much know why? Where do males tend to put some of their weight? A little more centrally, okay? So there tends to be a little bit higher prevalence of heart disease in those individuals who tend to put their weight more centrally versus females sometimes put it more on the hips, okay? So a good exercise program is helpful with that. So while you are going through exercise, if you've just had a procedure, if you've just had an event, sometimes psychologically that can be very scary, okay? And gosh, can I overdo things? That might be a frightening thing. So by going through cardiac rehabilitation, it helps with your emotional psyche, or whatever you'd like to call it, to make you feel safe. And in cardiac rehabilitation too, if we know that you'd have a physician's appointment coming up, we'd print off your last session, Send it to your doctor so he can review it, looking at your rhythm. Something that can help people feel more confident to do the everyday activities without feeling so stressed out. The other piece of that is the social support. It's nice to be around an area where you can talk to people who have had an event that might be similar to something that you had, to ask them questions. Did you experience this? Gosh, you're on this medicine? I have this too. This is something that I've noticed taking this medication. Why is someone taking the medicines that they're on? So just to help answer some of the questions that people might have about the things that they are going through cardiac rehab. Of course, we're trying to teach people to be active at home safely, especially if we can make it specific to what they would like to do. I like to find out, well, what do you enjoy doing? If you enjoy gardening, let's see if we can get you to a level of, it's called your functional capacity, so that that's comfortable. If you have grandchildren that you need to lift up, maybe a little bit more strength training to develop the upper body. Or if you're returning to work, perhaps we need to, of course, do additional things that would help you with returning to work more efficiently. We also have a Mended Heart support group, so that when you do continue, or when you're finished with your cardiac rehabilitation, you can come to our support group. That's available to anyone. We meet the second Monday of every month here in this conference room, and we have wonderful speakers who speak monthly. The one that we have coming up in February is Deb Seibert. Will be speaking on women and heart disease, and that is free to the public. So it's for anyone who's had any type of heart event, or their families or friends. And actually, the Mended Heart Support Group is raffling off a stationary bicycle to help. The funds stay here in Missoula, and it helps to pay for people who can't afford their cardiac rehabilitation. So if you have any more questions, I can certainly answer that on the raffle. How about the next one? So some people say, well, gosh, how long do I need to come to cardiac rehabilitation? If you are a lower risk, then perhaps only 12 sessions. But really, what we're looking for is a behavioral change, okay? And a lot of times you need at least 3 months to change a behavior. Sometimes it's very overwhelming for patients to hear, okay, you need to lose weight, you need to start to exercise, you need to take these medicines. Start off slow with some short-term goals, and maybe with a long-term goal of perhaps losing so much percentage of body weight, depending on if that's what an individual really is looking forward to. Some people are like, I just want to be compliant with my medication. Well, that's one we can work on. Okay, and the last thing that we like to do in cardiac rehab is we know that sometimes it's a very stressful event for people, so we like to have fun. So let's try the last one. This is an everyday occurrence.
This is an MRI of the heart. I wanted to start with a basic concept. The heart is a pump, and that pump is a muscle. The muscle is stimulated by electrical impulses. The heart pumps blood to the rest of the body, but it also pumps blood to itself. The coronary arteries, which sit on the muscle, carry oxygenated blood to fuel the muscle of the pump and the electrical system. The coronary arteries can occlude, become blocked off, and cut off the energy supply to the heart. Without oxygen, that heart muscle begins to die. Dead muscle causes the pump to fail. The failing pump delivers less blood to itself. This is the spiral, the circle. This is why patients become so sick so quickly. Now I want to start out with a case presentation. This is a 57-year-old male with no significant past medical history who had a sudden onset of vague chest pressure while getting dressed for work. His chest pain was not associated with shortness of breath. He felt a little bit clammy and he was kind of nauseated, sick to his stomach. He ignored the symptoms because he's had them before. The symptoms usually went away on their own. He then began his drive to work. Typically, his drive to work consisted of hopping on the interstate and getting off on the next exit, but they were working on the overpass, so he had to drive, thankfully he had to drive through town. As he went under the underpass, he lost consciousness, slumped over the wheel, and rolled through a red light at the first intersection. Miraculously, he hit a lamppost in the parking lot of the Press Box restaurant, and he came to a stop. A nearby jogger, who happened to be a paramedic visiting Missoula from Arizona, pulled him from the vehicle and immediately began CPR. These timelines are important. 911 was notified. An ambulance arrived in 8 minutes, and he was taken directly to the emergency room. He required 8 defibrillations or shocks en route to get him back into his normal rhythm. This was his EKG on arrival, and I know you guys don't look at this stuff, but these are what we sort of refer to as tombstones, these elevation in the ST segments of the EKG. This is an EKG of a heart attack. It should look a little bit more like this. And you have these big peaks, and that's what we pick up. When we did our physical exam in the emergency room, the patient's blood pressure was very low, 78/42. Heart rate was very high, trying to support that blood pressure. Patient was requiring a lot of oxygen, was unresponsive, pale, critically ill. Cardiac examination, heart rate was fast but otherwise normal. Crackles in the lungs from fluid buildup from poor pump function. Extremities were cold because they were not being perfused from a failing pump. Patient was placed on a breathing machine and was given medications to support blood pressure. The cardiologist on call immediately identified the problem as an acute heart attack with cardiac arrest. The patient was given aspirin, heparin, was given beta blocker as the blood pressure improved after they put him on the breathing machine, and was immediately taken to the heart lab. So the total time for all this stuff was about 45 minutes till he got to the cath lab, which is pretty good for out of the hospital arrest. So the patient was taken to the cath lab to look at what? Well, these are the heart arteries, they're coronary arteries, and they come off of the aorta, which is the big blood vessel in the heart, and then they course along the surface of the heart. There are 3 coronary arteries. The left and the right make up the 3. The left is actually 2 because it has this main branch called the left main that then forks into 2 other branches called the LAD and the circumflex, and then the right coronary artery is typically its own vessel. But we count them as 3 typically. They all have different segments that we associate the coronaries with, and they also have branches, different smaller branches that all have names too, kind of like a tree. Bypass surgery, just to mention this because I'm showing these diagrams right now and I'm digressing a little bit, but bypass surgery is where we attach these either veins or arteries that then go from the aorta and go over the area that's blocked so that downstream they can get some of those branches and supply blood. So the patient ended up having a coronary angiogram. This is a catheter that's injecting the heart with dye. And this is the left coronary artery like I was just showing you on the diagram. And there is a blood clot sitting in there. And you should be seeing a vessel here, but there's not. That little white dot right there is a blood clot that's occluding blood flow. And we looked at the heart muscle down here. It is just a little bit sluggish on the front wall, and that's where that artery goes. So our patient got angioplasty, and this occurred at a time before there were stents. So before stents were invented, we just had balloons, and they went in and ballooned this thing and opened it up, and now you can see that artery filling all the way down. And we do this over a wire, so we fish a wire through there. They're very, very small, and over that goes a balloon that's then put across the blockage, expanded, and we try and open things up and get blood flow. Our patient has a history of high blood pressure, which is untreated, allergies. His only medication was aspirin, which he was taking for a headache. He's married, local pathologist. He is a smoker at the time. His father died of a heart attack, so he has a family history. Has high cholesterol, the LDL is 178, HDL is 34. This is the good cholesterol, the bad cholesterol. And then these are cardiac enzymes. These are things that we measure in the blood when people have a heart attack. They actually come from the dying muscle. They're proteins and enzymes. And sometimes we can use this diagnostically. In this case, they were not helpful to us except to determine how big the heart attack was. So the patient spent 6 days in the hospital before being transferred to cardiac rehab. Today, 13 years later, the patient's alive and healthy with no symptoms of angina or heart failure. He's needed no other cardiac procedures, follow-up exercise, treadmill tests have looked good. He's quit smoking, lost 20 pounds, blood pressure and cholesterol controlled with medications. And I do this all the time, but this is my dad. And Stan Wilson was the cardiologist who saved his life and is now my partner. So I have a lot of reasons to thank Stan. Our next patient is, and this is a different case scenario. This is a 61-year-old guy with no significant past medical history who's been experiencing chest pain with exercise for the past 5 months. Not a heart attack, just suddenly started developing chest pain. The patient's very physically active. He jogs 2 to 3 miles several times per week. He's noticed chest pressure during his jogs, and this has gotten progressively worse over that period of time. The discomfort doesn't involve his jaw or his arm, which some people do experience. He's not been short of breath with this, but he has noticed that his ability to exercise has gradually gone down. He can now only run about a half a mile before developing the chest discomfort, stopping and then restarting to run again and trying to get through his jog. He doesn't smoke. He has no family history of coronary artery disease. He doesn't think he's ever had cholesterol problems, but doesn't know. And he was evaluated by his primary care physician, who was so convinced with the symptoms, decided the best test would be one of these new 64-slice coronary, CT coronary angiograms, so a CAT scan. So the patient went to the cardiac catheterization lab, and lo and behold, this blockage was exactly like what we saw on CT. Right there. Another look at it. You can see the blockage right after that area right there. So, and that was at least 70% or greater blockage. Patient's symptoms matched what we found. We felt that this was significant, and we decided to treat this. And this is a stent going in, and the stent is mounted on that balloon, crimped down like tightly on top of the balloon. The balloon expands, puts the stent, which you can now see is right in here, up against the wall. The balloon comes down and comes out of the body. The stent is there, and if you look real close, you can actually see it before the dye starts to go through. Little mesh work. Good time to stop. Mark Sands is in the cath lab, speaking to me from somewhere, I don't know. But it's typically the way my partners work.
How are you doing with your talk?
Oh, I don't know. Okay. Just go ahead.
This is a gentleman who was really pretty sick about 1 month ago, just after New Year's, when he went to the Polson emergency room after midnight and had an inferior or bottom of the heart attack. They recognized it immediately and started appropriate treatment. They called me right around 1 a.m. in the morning. This gets to the issues of living in Montana, because it was a pretty bad snowy night, probably one of the few snowy nights we've had this year. And they gave him the clot buster medication up there, but he was very sick. He was in what we call cardiogenic shock, so his blood pressure was in the 70s. He was in heart block, so his heart rate was in the 40s. And they gave all the drugs they could. We would have liked to have shipped him from Lifelight, but they couldn't go. So in the end, it took 4 or 5 hours. What was it? Something like that. 5 hours, he's telling me, to get down here. Interestingly, by the time he arrived, most of that had resolved, and his EKG looked a lot better, although was not normal. And he came to our cath lab. I assume you showed some pictures before. Let me show you what his arteries look like. This is about, I don't know, 5 or 6 in the morning.
Okay.
Go ahead and...
So this is the right coronary artery. This is the one that goes to the back of the heart. And what you're seeing here is a very severe narrowing. And this is actually a huge artery. It gets big branches, gets lots of heart muscle. And there is a 99% narrowing there. And it actually, if you saw this on the machines we're looking at, there is a little bit of haziness in there that would be a blood clot sitting on top of that cholesterol. So most of this is a cholesterol blockage with a blood clot mixed in with it as it's ruptured. Okay? This is the left coronary system. This was done also at the time when the patient came in with a heart attack. We look at all of the arteries and the LAD wrapping around to the tip of the heart, if we can freeze that.
Can you freeze it? Go
And
forward.
the patient had an area of concern down here of narrowing. So patients can come in with heart attack. The artery we figure out is the acute problem, the problem right then and there, but we frequently find other stuff. We look at everything, and it's all important in terms of how the patient may do.
Next.
Okay,
Next.
Mark?
Yeah.
So,
So you might show them there in that view. It's probably
so you did angioplasty, I'm assuming, on the right coronary artery and opened that up.
Just show them the heart muscle. Okay,
This
so
is-
here's his heart. You might point out the,
This is the ventricle, and this is where that right coronary would go, and so we want to see how the muscle is performing. And this is right after a heart attack, so
go ahead.
that you can see that it's not squeezing all that well. This is a little, Bradbury showed you the ultrasounds, and it's showing the same stuff. This is a ventriculogram, but it's showing that muscle has been weakened from the heart attack, and frequently that is reversible if you get the artery open and get blood supply. It's kind of like being punched in the arm. You're sore for a little bit, but it comes back. Sometimes it doesn't if it's been too long. So here's the stent going in.
Go ahead.
Keep going. And now that blockage is gone.
Next.
Blood flows a little bit sluggish because there's blood clot that's in there and other stuff that goes downstream and can block the smaller arteries. We have sometimes used devices to prevent that, little nets to catch the stuff. So how did he do, Mark?
He's done great. He was scheduled to come back to look at those other arteries, and that's why we're here today. He was going to come back Tuesday, but kindly consented to come in a few days early. If the blockage on the front of the heart looks the same way it did, then we'll go ahead and do another metal stent over there. I don't know if you were going to get into it, but you might want to talk about the controversy of drug-coated versus bare metal. That was a 4mm bare metal stent.
Yeah, we can talk about that.
So this is the right pictures we took just before while you were doing your talk.
Okay.
And so that's what it looks like today.
So the stent's still open. It looks good, Mark.
We'll just get
And the blood flow is much improved,
much
actually.
improved, right. We'll take a picture of the heart muscle later. I bet it's a lot better.
So you're going to take a picture of the left coronary right now. So this catheter was just threaded. Again, everything goes over a wire. We use bigger wires to move through the big vessels, but this catheter is specifically designed to cannulate the left coronary, and he's going to take a picture of the left coronary artery right now. And this is the left coronary artery right here. This is the area that we were concerned about. Now, some of these pictures look different to you because they're taken at different angles. These are two-dimensional images, but the coronary structures are three-dimensional. So we have to take pictures at different angles and then mentally piece it together to figure out what the true structure is like. Because there's other vessels that overlap, or they're, instead of going like this, they're coming right at you and you can't see anything. So we take a number of different views. That's why it looks differently. And here's the same artery. And that narrowing looks about the same, doesn't it?
Yeah.
Maybe even a little bit worse.
I'm not sure if you can tell, but we certainly see better pictures. This is in the new room today.
Yeah.
The other pictures were over in room 3, one of the older rooms. You can really see it nicely there.
Does everybody see that? That's right in the middle of the artery, and it's just a narrowing down here. Now, the patient's had a heart attack, and yes, those blockages can cause a heart attack, but they also can limit blood flow when you're exercising and just give you symptoms without a heart attack.
You might show them the one in the distal circ, pretty small vessel. But
There's also a blockage there. That vessel is much smaller than the other one we were talking about, and sometimes that's important.
Steve, you want to
Sometimes it's too small for our equipment to even fix.
So we're going to run Pion on this. Let's take a picture of his heart muscle. I suspect it's going to be a lot better.
Okay. Go ahead.
I guess you want to talk briefly while I'm setting this up here about, of course, he has one bare metal stent, so we could choose.
Is that what did you put in, Mark?
That's a big 4.0 bare metal.
So bare metal, there's been a lot of controversy in the literature about drug-coated or drug-eluting stents. I'm sure a lot of you have heard about this. Coronaries are 4 millimeters down to 2 millimeters, so they're very, very in diameter. They're very, very small. And the stents go in. You want them to heal, but not too much, because you can get scar tissue buildup that then slowly blocks that off over a month. And that risk can be as high as 50%. But it's typically a 20-30% risk with the bare metal stents. So drug-coated stents were invented to try and limit that scar tissue buildup. And one of the controversies has been the issue of getting a blood clot in the stent. And that blood clot risk goes down if you have more healing. The risk of getting a blood clot in a stent without any drug coating is 0.8%, so less than 1%. It's an uncommon event, but there's a lot of people that get stents in the world, a lot of patients, and and it's potentially very serious to get a clot in your stent. With a drug-eluting stent, that risk is about 1.5%. So again, 0.8% versus 1.5%. It's a small difference. It's uncommon, but it does occur, and when it does occur, it can be very worrisome. So we use Plavix for a longer duration.
Go ahead.
So this is a ventriculogram. This is looking at the heart muscle, and we inject a bunch of dye into the chamber of the ventricle. This is a pigtail catheter, because it looks like a pigtail. And it injects contrast dye. And this is the same heart ventricle that we saw those other pictures right after the heart attack. And you can there's a bunch of extra beats because it irritates the heart. But that very last beat, after a PVC or an extra beat, you can see there's right there, very good contraction, strong muscle. So his heart attack has resolved nicely. He's convalesced nicely from this. The muscle has come back and has been very strong, and it's not left with significant permanent damage. And that is a time-dependent thing. Had it taken longer for him to get that clot-busting medicine or angioplasty, there's more chance that that muscle would have died because blood supply was cut off. This is a three-dimensional reconstruction of the coronary that we can now do in our lab. We can see that.
Okay, you wanted to explain that?
So this takes the angiogram, different images, and reconstructs that segment. And why is that important? Why would we want to do that? Well, with this technology, we can make very, very precise measurements of the size of the vessel. And that's important when you're trying to decide on the type of stent you're going to use. We can also take this and determine the angle of a branch coming off and what it's going to take. So we use this as a tool to pick our stents and other things and try and fix the artery. This is a new technology. We're one of the few labs in the world that has it, and it's very useful. We use it for the leg arteries as well as the heart arteries.
Tell you what, why don't you can do more of your talk. We can set up equipment.
Okay.
I'll tell you, I'd be interested in yours, and I think if Stan Wilson's there, his thoughts. Bare metal or drug coated?
What's the size?
It's
It looked like 2.5 to me.
yeah, I'd probably use a 3.
2.5 millimeter to 3 millimeter. The smaller the vessel, the greater the risk of getting scar tissue blocking it off. Well, coronary artery disease is the leading cause of death in both men and women. If you took the 14 other leading causes of death, lung cancer, et cetera, added them all together, you still wouldn't come close to the number of people that die from heart disease every year. Women are 9 times more likely to succumb from heart disease than to breast cancer. By 2000, heart disease claims 60,000 more women than men each year. Prevalence today is 1.3 million people per year in the U.S. suffer a new or recurrent heart attack. And of those 1.3 million people with a heart attack, more than 500,000 die outside of the hospital within 2 hours of the attack. Another way of saying that is 50% of people die before they get to the hospital. And that has changed little historically. And I'll show you some slides. We've done very well if you make it to the hospital. We've done very well with our treatment if you get to the hospital. It's getting there. So this is a public health issue. 25% of patients had no prior signs or symptoms before their heart attack began. 24% of men and 42% of women die within 1 year of their heart attack. 22% of men and 46% of women develop congestive heart failure following their heart attack. So not only is there a risk of dying, but living with heart failure from the heart attack. And we have a lot of treatments and talk about how effective they are, but even a 1% reduction in mortality in the U.S. with heart attack would save 3,400 lives per year. Atherosclerosis is the word that we use for cholesterol in the arteries, coronary artery disease. They're all interchangeable. It is a slow process, and it begins in childhood, toddlers, 2-year-olds. Approximately 50% of all heart attacks in the U.S. occur in people that are younger than the age of 65, but 85% of the deaths from heart disease are in people over the age of 65. And as our population is aging, people are living longer. Heart attack is not only going to become more common, but the mortality from MI may actually go up with that. And as the population ages, heart disease in general is clearly going to become more common. So I have a little movie here I want to show you, and the point of the movie is to talk about how heart disease develops and kind of what a heart attack is. So here we are, we're zooming in, there's artery and veins on top of the heart, we're entering the coronary artery, and I think that we're going down the LAD right now. This white stuff is plaque, and in the arteries are blood components, red blood cells, I'm going to show this stuff here, and cholesterol. This is LDL cholesterol, low-density lipoprotein. This is the bad stuff. This is what you want low, LDL low, bad. HDL is the good stuff. This is sort of like the garbage removal system of the body. I mean, it gets rid of the fatty particles from the bloodstream. So HDL is a good cholesterol. Monocytes or macrophages are white blood cells. They're inflammatory cells. They're very important in the process of developing coronary artery disease. Red blood cells carry oxygen, and that's what you want to be delivering to the heart muscle downstream. So here we are now in the artery. The stuff's flowing by. Something happens to the artery wall, and this is poorly understood, but the LDL, these little cholesterol particles, the bad stuff, start bombarding that wall. And they enter into the wall, the actual thickness of the wall, take on oxygen, become oxidized, become really sort of pro-inflammatory, and the body recognizes this. And these monocytes come in, these inflammatory cells start engorging themselves on these cholesterol stuff, so much so that they kill themselves. And they just go splat and form these plaques, and this happens over and over and over again. And as that happens, this cholesterol starts to build up right underneath the surface of the wall. And then it starts to grow outward. It doesn't immediately start growing inward. It starts to grow outward long before it ever starts to grow inward and encroach on the artery. So now we have a big plaque in the artery, and it's not really obstructing blood flow yet, maybe 50%, but it ruptures. And a blood clot forms on top of this, and there's not a lot of room in here, and it may or may not totally block off that artery. But a couple things can happen. You can have a heart attack, or it can heal, because there's a tug-of-war going on and wanting to get rid of the blood clot and forming the blood clot. And this can be a way that plaques rapidly grow without causing a heart attack. So this is maybe a patient where 1 month ago things looked okay, and then suddenly they had developed more chest pain, and this is what happened rather quickly. This is also what some of our medicines are trying to prevent, both that plaque rupture and the growth of the plaque, or reduce the risk of having a heart attack. So aspirin lowers the risk of you getting a blood clot, or maybe just limit the risk of a patient having a blood clot. Cholesterol medicines like statins and stuff, Lipitor, Crestor, that kind of thing may prevent rupture altogether and may limit the size of the plaque in the first place. So inflammation clearly plays a very important role in the formation of blood clotting. And this slide is very simple, but the process is incredibly complicated with multiple things involved. Inflammation may also be very important in the initial injury to the artery that causes that cholesterol to just start going into the vessel. The majority, this may come as a surprise, it usually comes as a surprise to a lot of people, but the majority of heart attacks come from blockages that are 50% or less, meaning it's not these big 70%, 99, 95% blockages, these that are older and more severe, maybe have a lot of calcium in them. It's not those that are rupturing and causing a blood clot. It's these young, friable, growing plaques that become unstable and cause heart attack. Plus, there's a lot more 50% narrowing than there are these dinosaur, really old 95% narrowing. So it makes it somewhat challenging picking up heart attack on stress tests, or risk of heart attack on stress tests. And that is why it is so important to know your family history, your cholesterol level, what your blood pressure is, and try and minimize all of that risk by eating right, exercising, taking the right medications if you are, in fact, at risk in certain cases, and try and lower your risk of heart attack. Stress tests try and pick up the blockages that are 70% or greater. Now, with all this stuff going on, we have names for things, but a person can have no symptoms at all, be going along and be doing just fine, and then can have the slow growth of one of those plaques and develop something called stable angina. When it first comes on, we want to look and find out what's going on and the extent of it. Or a person can just have a heart attack, and there are big heart attacks and small heart attacks. Patients can go on to die. They can go on to develop heart failure. They can go back and forth. Unstable angina is having any change in your chest pain pattern, more of it coming on at different times, coming on at rest. And a lot of people can go on to have no recurrent symptoms, particularly with medical therapy and angioplasty or bypass surgery. There are risk factors for heart attack. The traditional ones we talk about are family history, high cholesterol, high blood pressure, diabetes mellitus is a big one. Smoking, secondhand smoke, obesity, physical inactivity. But there are a lot of other risk factors, things that we're just studying now. Homocysteine, something that people have probably heard about, and C-reactive protein, which is an inflammatory marker. Remember I said inflammation is very important. Periodontal disease, and there's many others. The symptoms of a heart attack, and Brad went over the symptoms of heart failure, but the symptoms of heart attack are chest pain. This is the foremost symptom, but not everybody has it. There are a lot of other causes of chest pain, so the nature of the chest pain is very important. Arm pain, left arm, both, unusually just the right. Lower jaw or neck discomfort involves the mandible. Very, very common. Upper back pain sometimes. There are other things that can cause that, but heart pain is one of them. Shortness of breath, very frequent, very common in women. also very common in men. Change in exercise capacity. Diaphoresis, or sweating, intermittent sweating. Nausea, upper belly discomfort, feeling tired, pretty nonspecific, but that's another thing that a lot of people have is the sensation of being tired. Syncope, or just passing out.
Todd,
Yeah.
when
Yeah.
when
You
get
bet
to-
you're back?
We're back. When you
All
get
right.
to a point where you can,
This will be a good place to stop. 25% of people may have no symptoms at all. I see a balloon and no stent.
right, okay, so that's what a balloon looks like when it's blown up. And then Teresa,
That's not transmitting. Oh, there we go. This is a stent.
that's an
Metal stent in
expanded,
there.
I think that's a 3 millimeter expanded
It's in a
stent.
gelatin thing here.
To the-
So where are you, Mark?
Okay, we have a wire. Go ahead and show them first of all, what you going to show first? Workstation? Okay, show them the workstation so we can see where we're heading. They can see where we're heading.
Okay. There's the lesion right there before that blockage. LAD, and it starts to narrow down, and just right there.
Okay, now let's
Right.
go live, Floro.
There.
So what we have here is, we have the stent in place, wires ready to go. If you want to
There's
just
a wire
show.
here that he's fishing through. This is a stent on a balloon that's not deployed yet. It's as small as we can get it. It's going to go over that wire, but he's pushing the wire now, trying to get it through. And we put a little bend on that wire so that we have some way to direct it through
You
these
may-
blockages.
You may have talked about calcium in the wall of arteries, I don't know, but you can point out here all the calcium that's in the wall.
There's some haziness. It kind of looks like smoke there. These are ribs in the background, by the way, but that smokiness stuff is actually calcium that's being picked up by the X-ray in the artery. And that calcium, goes into the cholesterol plaque. Really old cholesterol plaques start to take on calcium as they age, and that calcium makes the arteries rigid. Sometimes challenging for us to drive these metal stents and things through calcium because the artery doesn't bend or flex for us. So you're positioning the stent now, I see. What size stent is that, Mark?
This is a 3.0 by 13 cipher drug-eluting stent.
Okay. So there's two little dot markers that are showing the one end and the other end. We use that to position it so we know exactly where the stent's going to be. We can shoot dye around it and see that he's already got it across the narrowing there. And
Deploying.
stent here,
Cover 12.
wire, positioning. Now the stent is going up. You just inflated the balloon and the stent's going to expand. We try and use as big of a stent as we think we can. Bigger is better.
Yep. 12 for 35.
So you can see the contrast coming out.
So now the balloon is back down. What Mark just said, we actually put contrast
Get
that's
some
picked up by the X-ray in the balloon itself so that we can see it expand. We have a pressure gauge so we can tell how many atmospheres of pressure we put into it.
We'll show you that
And
here.
there's a scale that we know. So if we take something to 14 atmospheres, we know that that extent is going to get as big as,
Can you show?
this
can you
is the pressure monitor, and we can take that up on the balloon. And so each stent is a little bit different, but we read and say at 14 atmospheres, this 3 millimeter stent will be 3.1 millimeters or something like that. B. We then remove the balloon so that we can take a picture of the heart artery again. The stent went in right here. Here comes the picture. Now you can see the stent at the artery open and there's no longer a blockage there. That's good flow.
So, I don't know, distally,
These stents will sort of conform to the arteries too a little bit. If you're on a bend, they'll be on a bend and they'll take
let's
on
give a little
that
nitro.
shape.
Yeah.
So that's an angioplasty or stenting when you talk about that. We try and use stents whenever we can. stenting is better than just a balloon, but there are certain situations where stents cannot be done, and for a long, long time, we just did balloon angioplasty, and you can get very nice results with just a balloon in some cases.
I'm giving a little more nitro in the hopes that that distal edge, and pull back the wire. Hopefully that distal portion will look a little better.
Everybody see the stent in there, and it's a lot more obvious now because the artery is bigger right there. But he was worried about this downstream area and whether he needed to put another stent in to cover that area as well.
There.
Also notice we stented right, this is a very small branch, and we just stented right across that. If that branch was big enough that it was of any clinical significance, we'd sometimes have to go in and work on that fork in the road. So not only that branch, and we can go through the stent with another wire and balloon that, or even put a stent in a Y configuration. Something that Stan Wilson has been working on is a stent that actually is a Y. This branch is quite small and is not something that would require any further treatment. Plus, he has great blood flow into that.
So that's kind of the final, right there, after we pull back the wire. So I think
So-
our
so-
part is over, I think.
Yeah, the nitro really
It really
made
helped
the
pull back
artery
the wire.
improve in size. How do we follow up on the stents or see if it's filling up with stuff? You know, the stuff is the scar tissue, and if that is happening, patients will get their symptoms back. We do stress testing after stents have been placed. We don't do routine angiograms and go back and look and do another invasive test after somebody's had a stent. And we also have a level of suspicion based on the patient, size of the vessel we stented, whether they're diabetic, did they quit smoking, all of those kind of things. So it's really a clinical follow-up, and it's following up with your doctor. Stents can never be removed. And technically they could be, we never remove them. They could be removed with surgery where they'd have to be removed, but there's no way to remove a stent. And once they're in there, they're in there. They don't move around. It's very, very, very uncommon for a stent to become infected. That's just not something that we see. It has been reported, it's not something we see.
Stents themselves, but
The hardware consists of, first of all, a sheath that we put into the femoral artery, typically. We can go from the arm and other places. Typically, the right femoral artery, that's just a convention. There's no other reason. It's just easier to work from the right side. It's the way things are set up. A sheath is like a one-way valve. We can put it into the artery. It's short, about this long, and it has a one-way valve so stuff can go in and out without patient bleeding at all. And
Are
we
we
get
live?
that sheath in there with a needle. We don't
see this. Are you
cut
live?
it open. Yeah.
Showing you the wire here, if we can you see that gap?
Through
There
that
you go.
sheath goes a catheter up to the heart arteries, and then everything is delivered through that catheter.
Keep going.
This is a wire.
how-
They're made of various metals. They're very, very high tech. The
And then-
tip is typically soft, what we use. We do have other wires that are not so soft, some that are very much not soft for trying to get through total blockages. Some of them are hydrophilic coated, meaning that that when water gets on them, they're very, very slippery.
This
They
one
just
is,
slide along.
these are incredibly
And
soft.
He's put a bend on the wire there so that he can direct it. And that degree of bend is physician shaped, and it depends on what we're trying to fix. Sometimes we put long bend, short bends, minimal bend at all. Over that wire goes the balloon or the stent. Sometimes we will balloon something without a stent so that we can get a stent there. So we'll open it up a little bit, take that balloon out, then take a balloon with a stent and place the stent.
It just gives you an idea of the guide cap.
And then everything comes out. We leave nothing but the stent. It's the only thing that gets left. That's a catheter, a guide catheter. They have different shapes at the end, and those are a hollow tube, and that little turquoise tip at the end is what sits in the coronary artery, right at the cusp of the coronary artery. And we're very, very careful with these. Move them minimally. So we all work in millimeters up there from the right femoral artery. Women, it has only been recently that we have started to, as physicians, address the issue of women and heart disease. All of our earlier studies were biased towards men. Physicians had a bias towards men. Those biases are complex to sort out. They may range from not believing that women actually have coronary artery disease, that their chest pain in the emergency room is something else and not a heart attack. There was the concept that estrogen protected women, and it might actually, while patients are premenopausal, their own estrogen, not taking estrogen, which is a totally different issue. Women in general present with coronary arteries about a decade later than men. In general, women are sicker than men when they present, more diabetes, more high blood pressure. It also turns out that women are getting a slightly different type of coronary artery disease than men. Not all women, but some women are getting a different type of coronary disease called microvascular coronary disease, meaning it involves the teeny tiny small vessels, those branches and downstream, and not just one or two of them, all of them. And that can affect blood supply, and it's not very conducive to stenting. But women do get classic coronary artery disease just like men, where you get an area that's a hot spot and it starts to build up. I think that a lot of the increased mortality, increased heart attack risk comes with the fact that patients that are women are older, they have more diabetes, their symptoms may have been not recognized early enough. There are some issues with testing and trying to risk stratify, if you will, women. This is one study of 515 women, so this is a small study in our business. And it looked at the symptoms women had and how they compared to men. This is one of the earlier studies. It's from 2003. What were the symptoms that women had 1 month before they had a heart attack? 70% of them had fatigue. Fatigue's pretty nonspecific. A lot of things can cause fatigue. Sleep disturbance in 48%. Again, a lot of things cause sleep disturbance. Shortness of breath, a little bit more specific. 42% of women a month before they had a heart attack had shortness of breath or a change in their exercise capacity, but only 30% of them had chest discomfort. When they actually came into the emergency room with a heart attack, the symptoms they were having at the time, 58% of them were short of breath with their heart attack, but look at this, only 57% of women were actively having a heart attack had chest pain in this study. 54% were weak, 43% fatigued. Weakness of fatigue, again, very nonspecific, wouldn't always make you think of a heart attack. Comparing them to men in this study, women were 68, 69 years old, average age. Men were 60, so almost a decade older. Minutes before they actually came to the emergency room in this study, women waited 198 minutes versus 138 minutes before they actually came in. 53% of women in this study had diabetes versus only 23% in men. A much higher percentage of diabetics. Diabetics do worse with coronary artery disease than non-diabetics. High blood pressure, higher percentage in women. About the same, but a little bit actually in this study, women had more chest pain right beforehand than men did. Cardiogenic shock, very low blood pressure, very, very sick when they got there. 25% in women, 10% in men, so they were sicker, and that reflects the diabetes and presenting later. And then the number that got that clot-busting medicine, received thrombolytic therapy in the emergency room. So still in the ER, no angiograms done. They're just listening to the patient and then deciding about a clot-busting treatment. 24% for women versus 41% men. This is a physician bias. But if women made their way to get an angiogram and we actually looked at the arteries just like men instead of all the symptoms and talking to the patient other thing, but just see what the problem is, there was no difference between the rates of getting angioplasty or bypass. It was getting there that was the issue in this study. And this translated to mortality. Early 1-month mortality and 6-month mortality for women was 18% versus 8% for men. At 6 months, mortality was 26% for women and 11% for men. So clearly there's something going on, and it's a complicated issue.